Good morning. On behalf of Team AIG, I welcome the distinguished guests and faculty members to our third Dietetics Day program at AIG Hospitals. Over the last decade, nutrition and clinical dietetics has evolved and transformed our lives for the better. At AIG, we strongly believe that we need to educate both our patients and our community of healthcare professionals to achieve nutritional adequacy. In line with our motto, last year a seminar reiterated on how body composition analysis can be correlated with nutrition therapy. Experts shared their opinions and skills on ways to assess and estimate the muscle and fat mass. I can say with pride that my fellow dietitians have taken their take-home message seriously and executed the same. Today, we have gathered here to discuss and enunciate the dynamic shift in nutrition caused by the minute component in the human body, the gut microbiome. Recent studies have reported that the type and composition of microorganisms in the GI tract can be used to assess one's health status. And this brings us to our theme, paradigm, precision amplified rational in dietetic innovation for guided management, focusing on every possible angle to make a strategic plan for a better future. I request Dr. Nageshwar Reddy, Chairman and Chief of Gastroenterology, AIG Hospitals, to welcome and elaborate on our theme.
Thank you very much. Again, on behalf of the faculty of the AIG, I'd like to welcome you all to this very important meeting. Over the last few years, especially as we know from the GI angle, nutrition, fiber, gut microbiome have become like equivalent to health and disease. And this triangle is something that has been explored extensively in scientific literature. So I'm extremely glad that the nutrition department in our hospital, headed by Dr. Radha Reddy, has come out with this paradigm, I think, which is important in the sense that now I think all our body functions are being regulated by the gut microbiome, which is regulated by what we eat. And in that sense, I think this is a very timely conference. I'm also extremely surprised that the auditorium is so full in the morning. In fact, this is a very good sign that this is going to be a especially successful meeting. And I'm extremely thankful to the eminent faculty that have come to give us talks on this area. And I'm sure this will be a very productive meeting. So thank you once again for organizing this AIG.
We will now begin with our scientific session. I request the dignitaries, Dr. G.V. Rao, Dr. Vishwanathan Gela, and Dr. Deepa Agarwal to take this dais, please.
Yes, now it's working, right. Very good morning, one and all. And I'm actually extremely glad to see such a crowd and huge enthusiastic crowd actually. In this session, we have the first talk being delivered by Dr. Roopjyoti Taludkar. Dr. Roopjyoti Taludkar is a consultant pancreatologist at AIG Hospitals here. He has done some pioneering work in chronic pancreatitis, its mechanisms, the pain of chronic pancreatitis, and how the gut microbiome actually leads to chronic pancreatitis and its relation, all these things actually. And he has published in many numerous indexed and prestigious journals actually. With this brief introduction, I would request Sir to start his talk on the microbiome and modulation of this gut.
Very good morning, and thanks Vishwanath for that kind introduction. So before I begin, I think I should congratulate Dr. Radha for this meeting, which she has been bringing up every year very meticulously, and it's heartening to see such a full hall. So the job that has been assigned to me today is to speak on, does gut microbiota modulation improve clinical outcomes? So what do we mean by this? How do we modulate the gut microbiota? So there are several ways to do that, like probiotics, prebiotics, symbiotics. These are all, this comes under fibers, and I'm not going to take Dr. Jalil's talk today on fibers, so I'll restrict myself to more of the dietary interventions with your rainbow diet and other dietary interventions that you do so beautifully. But before going to this, let us take 2 steps back and have a brief overview of the microbiota. What is the microbiota? So that we get a perspective of what we are going to speak on the interventions. So usually, in general, when we talk about microbiota, people usually have the notion of only bacteria. But the microbiota is actually composed of the virome, which is the most important and most abundant component of the microbiota, bacterium, fungum, protozoans, and archaea. So today I'll restrict my talk to the bacterium. So from where did this bacteria come actually? So it had been there since 4.5 billion, 3.5 billion years. It evolved from cyanobacteria, and it stuck onto all the domains of life and then passed on to the humans and evolved as the human beings also evolved. And then when the human beings evolved in Africa, from there, along with the human being, it diversified to the entire globe and adapted to the environmental and diet situation in those areas. The other important question is, has the microbiota been the same? Because it has been billions of years, so has there been any changes? So this is a very elegant study published like 10 years back, where the authors had tested the microbiota in the stools of mummies, 8,000-year-old mummy, 4,000-year-old mummy, and compared them with the normal modern human gut microbiota. And if you see here, if you see there is significant overlap between the modern microbiota and the ancient microbiota, which means that significant preservation of the microbiota has been there, and that has been seen mostly in the microbiota in the rural habitats, people from the rural origins. And to prove it further, 10 years after that, this another elegant study published in Nature showed that the bacteria like Prevotella, Eubacterium, these are, most of them are actually known. What was present there, we know it still now, which means that there is significant preservation. And this has significant implication to the Indian context, and I'm going to tell you why. So this was a study that we had conducted in tribal Indians from Northeast, North and South India, where we could see some specific signatures of organisms in those areas. And when we mapped out zone-wise, we could see lots of Prevotella, Faecalibacterium, Eubacterium, Collinsella. So these are all supposed to be good bacteria. And then when we looked at the other organisms from the other sides of India, we could see the same kind of organism of Prevotella, Faecalibacterium, and these were actually the core Indian gut microbiota, Prevotella, Faecalibacterium, Roseburia, and Ruminococcus. And why do we say these are the good bacteria? Because they produce something called short-chain fatty acids, predominantly butyrate and propionate, and these 2 short-chain fatty acids are responsible for the gut mucosal health, the intestinal health, the colocyte health, maintaining of the gut barrier permeability, metabolic regulation, anti-obesity, anti-atherogenicity effect. And this is very important for the dietitians and nutritionists to know, because now there are molecules that are available or that could be generated which gives you more butyrate and propionate. So you have another strong tool in your armamentarium of treating by doing a focused precision treatment with short-chain fatty acids. So the microbiome that we have actually now is, we are basically a giant culture plate. 90% of our body are bacteria, 10% are human cells. So basically, we live in the bacteria, what I feel, not bacteria live within us. And we have more than 100 trillion bacterial cells, and the bacterial genes are 15 times more than the genes of our human functions. And majority, 90% of these organisms are composed by the phylum, Firmicutes and Bacteroids, and the rest 10% are by the others. And below this phylum, there will be several other categories like the class, family, finally species, and strain. And it is the strain that is most important for conducting the metabolic function. In the probiotics, if you see the commercially available probiotics, you'll see the bacteria has a strain name. So it's very strain specific. The metabolic function of these bacteria are very strain specific. That's another important thing that has to be remembered. So if we look at our human colon, as we go down from the esophagus to the colon, there will be a significant change in the type of organism, the number of organism, and 70% of the whole body's microbiota actually resides in the colon. So the colon is a very big business hub for metabolic function, for microbial function, which gives us all the healthy effects. So what shapes the microbiota? This is another important thing that becomes very important as we go through the talk towards the later part to understand, because this has lots of bearing on which the dietitian can work upon. So the first microbiota we get during birth, and the best way to get delivered is a vaginal delivery, but now the fashion is to go for cesarean delivery. I'm not going to that aspect today because of time, but there are several health aspects from cesarean delivery. That's what I can tell now. And there are various other factors, like from where you come from, the type of initial diet, initial food you had, processed food, geography, genetics. All these are somehow affecting the diet, but the most important thing, Dr. Reddy has also alluded, is the diet. What we eat, that determines the bacteria eventually. Even though we come from different geography, it's the diet in that geography that will affect your microbial health. So and since this is a dietetics day, so let's go a little bit into the diet and the microbiome. So how can this diet help us? So usually breast milk is the best form of early nutrition, but and every one of you know this, I don't have to tell, but let us look at this, what can harm the organism. So we all have our fast foods and junk foods, and we all know what mayonnaise is. All our sandwiches are layered by mayonnaise, the pizzas are layered by mayonnaise. So this is the mayonnaise that we see. But mayonnaise actually, how it is, this is what actual mayonnaise look like. So why do it forms like this? It is because of emulsifiers and the preservatives. If we talk about these junk food, it's the preservatives. Actually, these are preservatives that causes more harm than the chicken itself or the sandwich itself. And there are elegant papers which tells about the different types of specific preservatives and emulsifiers that can cause bacterial dysbiosis. And then this is a very elegant study that was published in Cell a couple of years back. So what the authors did was they evaluated Thai immigrants from Bangkok, Thailand to USA. So this was how they looked before immigration. They used to have a vegetarian predominant or pro-health promoting non-fast food diet. And when they migrated to USA, initially they were similar as the native Thais before migration. But as they passed on and stayed longer in the US, their BMI increased, their microbiome profile increased, the microbial enzyme increased, and all the bad organisms started growing. And that was very similar to the European, American, and second generation US-born microbiota. So this clearly shows that diet definitely has a role in shaping the microbiota and eventually the health effect that it has. Let's look at the chicken in 1957. So what you see here, as the chicken aged after like 2 months, at that time the weight of the chicken was less than 1 kg. But if you look at today's broiler chicken, so it reaches 4 kg from just 44 kg. Why does it happen? We all enjoy our broiler chickens and we all enjoy our non-veg meat. So this study actually showed that there was significant difference in the bacterial diversity in the chicken cecums, chicken gut, and then 40% of these chicken contained antibiotics, and at least 17% had residues of more than one antibiotic. What does it mean? To maintain these poultry, be it chicken, be it other form of poultry, they give lots of antibiotics to keep them protected, and that leads to their obesity. So basically by eating this or allowing people to eat this, we are asking to eat them loads of antibiotics rather than the meat. So this is very important to understand why this poultry can be harmful. It's not because of the meat part, because of the preservatives and because of the antibiotics that is used in them. Right? And then another very upcoming thing is titanium dioxide nanoparticles. It looks very fancy, but if you look at a toothpaste, the simple things just a toothpaste, all your preservatives, they contain titanium dioxide. In toothpaste, they use it for teeth whitening, but these have immense effect on the microbiota. So probably grandma's remedy of using meswak branches of trees were probably better, and hopefully that will come sometime in the future. Again, I talked about antibiotics. So there are several Antibiotics, commonly used antibiotics that can cause long-standing effect or changes in the microbiome. And this is where I think we should have a word of caution. Please use antibiotics responsibly. I know dietitians, as dietitians, you may not prescribe, but you have all the right to ask this physician why they're prescribing. Is it rational? Because if we look at the statistics, in 2050, more than 4 lakh people will die because of antibiotic resistance. So this is alarming. And right now we don't have any new antibiotics for the last 10 years, and probably the same thing is going to happen in the future. The other thing that affects is the migration now. Lots of migration happening within India and inter-country. Again, lifestyle. If we look at 15 years back, the TVs used to be bigger, the people used to be smaller in size, and now the reverse have happened. We have become bigger in size, and the technology had made the TVs and our mobile phones and chips smaller. So this change in lifestyle, a sedentary habit, is also one of the responsible factors. So as dietitians, when you are talking to your patients, these are also important component that has to be addressed. It's not just about writing the diet or giving dietary advice. So these are more important than the diet, I think. And then finally, stress. How many papers my colleague have published? What new car have my neighbor has brought? My neighboring dietitian has like 100 patients, I have only 20 patients, so the stress. So this stress can also lead to lots of changes in the intestine and the circulation. There are things called psychobiotics, again I won't go into that in details, but stress has to be managed. So there is something called the brain-gut axis, which have a relationship in the metabolites in the brain and the intestine, and that leads to the perturbation of these things. So what does the microbiota do? This I have already discussed. I won't go into the defensive and trophic action, but we have talked about the metabolic action, and just let me give you a snapshot of what it does to glucose homeostasis. So microbiota is known to metabolize and synthesize and metabolize different amino acids. So this group of organism would metabolize tryptophan, which will lead to these end products of tryptophan, and all these will have glycemic control effects, like it will increase GLP, insulin secretion will be increased, glucagon secretion comes down, so and so forth. So basically the point here is microbiota do not work by itself. It works through metabolites. It works through crosstalk between the different organisms and different metabolites, and that is what is important. So this is about the healthy microbiota and the healthy metabolites. If we are taking too much of unhealthy food, so they will have lower richness and firmicutes comes down. There will be lots of bile degrading bacteria, and then there is a production of something called TMAO. And this is a proven deadly metabolite for which is responsible for cardiovascular disease. It initiates atherosclerosis. So it's not only about having a bad bacteria, but also having the bad effect of the bad bacteria, which is atherosclerosis, and which will be also associated with glycemic abnormalities. So now let's switch the gears to diseases. If you attend any gastroenterology or microbiota meeting, there will always be a question: is the microbiome, is the bacterial dysbiosis an effect or a cause? The chicken or the egg story, it still persists. However, I think the chicken-egg story has been resolved, because for the chicken to evolve from something else, you need a genetic mutation or alteration, and that happens in the egg. So the chicken or egg story, the egg came first and then the chicken. But in this microbiome concept, the chicken or the egg story still persists. We are still debating which is the cause, which is the effect. In fact, there is a very compelling evidence that was published several years back in Nature. So these are the two cute-looking healthy rats. So they were given feces from an obese mouse, and one was given feces from a normal mouse. And the mouse which got feces from the obese mouse became obese. So that's, I think, one of the most compelling evidence that gut microbial dysbiosis is responsible or is capable of causing disease and other bad adverse health events. So, so far, now we have data that has shown a cause-effect relationship with several diseases such as inflammatory bowel disease, pancreatic cancer, colon cancer, diabetes, atherosclerosis, obesity. However, there are several other diseases. Almost, I think, any other disease under the earth, under the sun, has been associated with microbial dysbiosis, which we still need to prove, and this is where the chicken or the egg story still persists. So how about modulating? If we modulate the gut microbiota, can we improve the outcomes. So I'm not going to talk on probiotics, prebiotics, and fecal microbial transplantation per se, but this is an elegant paper from AIMS that was published last year, 2022, where it was from Vineet Ahuja's group, where they compared patients with inflammatory bowel disease. They gave one group a standard medical therapy, the other group was a combination of fecal microbial transplantation with an immune diet. And the results were very exciting, which shows that patients who were getting a combination of FMT and immune enhancing diet, all their outcomes were significantly better than standard medical therapy. So the issue is here, there was no arm of combination of FMT and diet alone. But suffice it to say, it gives a suggestion that the addition of an immune modulating diet could improve the outcomes of IBD along with other treatment. So this was another very elegant study where the authors used, so this was a study in obesity, and a weight reducing Mediterranean and Mediterranean green diet was used for the patients. And during the weight reduction period, they took the stool samples and made it into capsules and stored it for future use. So once the weight reduction was achieved, desired weight reduction was achieved, then they gave these patients their autologous fecal transplant through the form of capsules, and one was a placebo group where they did not give anything. And if we look at the results, just concentrate on these line diagrams. So there was significant weight loss with the Mediterranean diet, but when the diet was stopped, there was a tendency for weight gain. But the people who got the FMT from autologous FMT, the rise of weight, the weight regain, and the insulin response was significantly better, significantly improved. So that means that if you give a good microbiota to these patients, they have a lower tendency to regain their weight or lower tendency to have a dysglycemia. Another example of fibers, again you'll hear about this in more detail later. So in this study, 4 types of fibers were tested, like double corn starch, and these are all resistant starch, undigestible, fermented, the 2 types from maize and tapioca, and then another potato-based starch. So if you see here, out of these 4 studies where the dose escalation was done for each of the starch, only 2 of them had shown significant benefit in the increase of organisms, the good organisms. There's butyrate and propionate, which are the good short-chain fatty acids, and they had health-promoting effects. So this again opens up a new field of research, which we can maybe call fiber engineering. So we can tweak around with the fibers and make them more pro-health, or we can make them more tuned to produce more of good organism and butyrate. And in fact, if we talk about Mediterranean diet, lots of components of the South Indian diet, which we all have lots of similarity with the Mediterranean diet. And I think Dr. Rupa Banerjee and Dr. Radha Reddy's team had done a great job by creating this IndiMed diet. And this was tested in some of our colleagues, and maybe they can discuss the diet later. I don't have time to go through it, but there had been several health promoting effects. So the data will be published soon, and you'll be able to have a flavor of how the results look like. The other important aspects is what, again, this is important for dietitians. You have to ask the history of what kind of diet the patients were taking before formulating a diet for them. Why? Because again, this study clearly shows that the type of diet that you were taking can impact the effect of the diet modulating effect of whatever diet you give. So this patients taking Amerindian diet and plant-rich calorie-based diet were given to notobiotic or germ-free mice, and when they tried to increase the weight of the germ-free mice, the effects were starkly different in the mice which were previously from the stool of the people who were previously taking American diet. So previous dietary preference has also an effect on how your diet preference or prescription would work. So I think I'm coming towards the end. So if we talk about this summary of the microbiota directed diet intervention, 2 things are very important. One, it has to be habitual. It should not be a 1 day or 1 week or 1 month business. It should be long enough, 6 months, 1 year. Then only the change in the microbiota will be sustained, and then only the health promoting effect will come. So by giving some diet, need not expect that in 1 month time the patient will become like gain weight and become healthy. Few other important things that needs to be considered while designing your diet is the dietary content, what he has been taking, what he had been taking. Food matrix interaction, this is very important. You know about this more than I know, but basically the types of food that you give in one serving, how they interact between each other. So that is extremely important, and that can also impact the microbiota. The resident flora, what the flora we already have, the patient already have. Is it a permissive flora or restrictive flora? So if the patient has a permissive flora, means the new changes will be welcomed by the resident organism. If it is a restrictive flora, the new changes will not be allowed by the resident organism. It's just like a villain and the hero story. Right? And the other important thing which you do not pay importance is the circadian rhythm. So people who has all this transatlantic flight, probably Dr. Reddy might have a, but you have, I know you have Ackermann's, so you won't have dysbiosis. So this circadian rhythm have a significant effect. Like if you do not eat on time, if you sleep late for some, and that's why you might be noticing before exams or some assignment, if you are not sleeping well for a few days, getting up late in the morning, you might have some bowel issues. You may get some temporary change in your, I think I'm seeing many heads being nodded, so they agree, so that's true, right? So it's very important, the circadian rhythm and the timing of intake, where because the body has its own physiology, it will secrete the enzymes at a specific time that has been tuned genetically. So if we try to mess up with the timing, again, that may cause alteration in the gut microbiota, and then whatever the dietary intervention you do may not get fully effective. So finally, the take-home message would be, this would be an ideal situation where we know about the patient's dietary pattern, lifestyle, drug history, health status, microbiome, metabolome. So by combining all these things is what that gives us something called precision nutrition. But in real life clinical practice, this is not possible. We cannot assess the genetics and metabolites and microbiome to give a dietary advice. So at least these are the things which all nutritionists should make a point to assess. It's not about just asking what disease you have, seeing the prescription, seeing the reports and give a diet chart. No, it's very important to assess all these aspects, and based on that, a diet chart has to be advised. And finally, I think in the near future, machine learning can come to our help, and that could probably take care of all these parameters and predict if our nutritional therapy would help the patient or not. I think I'll stop here and I'd be happy to take questions. Thank you very much.
Thank you so much for an amazing talk, sir. Actually, you have told us so many interesting things, actually. Simple things like a mayonnaise, a toothpaste, and the chicken, which generally a lot of people eat, have a lot of preservatives, which leads to change in the microbiota. In our pulmonary medicine practice, we see that when we put patients on Mediterranean diet or strict anti-inflammatory diet, some of the times we have seen their asthma control gets better. I think much of this has to do with the change in the microbiota, actually. Yeah. And we are fond of mayonnaise. Actually, probably next time I would think twice or thrice before eating a burger with mayonnaise.
Mayonnaise without the preservative. You can have that raw liquid mayonnaise. That's fine.
Liquid. And with this brief comment, I would like to take the comments. G.V. Rao, sir.
Any questions from the floor? I think looks like actually gut microbiome seems to be the in thing now. I think it is emerging as a biomarker for tomorrow. It's used for diagnosis, treatment, prevention. And I think there are a lot of changes that are happening. Actually, people are changing their food habits. I think personalized diet seems to be the in thing as in today. Yeah. I think each one of us should have like our own personal chef, maybe to regulate our bowel, so that we diagnose, treat, and prevent disease in future.
Right. Yeah. So coming to Vishwanath's point on asthma, so it has been very nicely shown that cesarean section delivered babies have childhood atopies, childhood asthma. That has been proven. So. Yeah.
So I think we require Dr. Reddy's comments on this personalized diet, actually, because I think he's a very strict follower of his diet regimes, actually. I think
Roop, that was a fantastic talk. I think a lot of new data, and you can see from his data that all the papers are from Cell, Nature, and so on, indicating such high impact journals. So I'm becoming a strong believer in modulating diet and microbiome, and then what happens. The only issue is that the chicken and egg story is very strong. So we don't really know whether when you become lean, whether it's microbiome that's contributing or the microbiome makes you lean.
Right.
So there's a lot of controversy on that. And of course the dietary fiber, I think next talk is on that, is going to be a very important component. So I think we have now the last 5 years at least very strong evidence that manipulating both the diet and microbiome may have substantial beneficial effects on the physiology. And I think this Akkermansia mucinophilia is an organism that you should look out for, because taking a lot of that seems to help in general also. Thank you, Rup, for the nice.
Thank you. Thank you.
I welcome Dr. J.V. Sir, Director and Chief of Gastrointestinal and Minimally Invasive Surgery, Chief of DNB, Surgical Gastroenterology, to welcome our next speaker.
It gives me immense pleasure to introduce one of the most eminent speakers in the field of diet, Dr. Jalil Ben-Yaqub. Actually, his CV is very, very enviable, a biochemist and an immunologist, a very rare combination, and he's climbed up the ladder to become one of the leaders in pediatric nutrition. One of the most difficult specialties that we have to tackle is the pediatric nutrition. And for the last 4 years or so, actually, he heads the Department of Pediatric Nutrition at Nestle. And surprisingly, he deals with communication and development of this, which is a very difficult specialty, especially in pediatrics. To his credit, he has got more than 20 patents to his credit, actually, so he must be very, very rich, basically, and more than 50 publications in high-impact journals and peer-reviewed journals. It's our pleasure to have you here this morning with you, and we'd like to hear from you about the role of fiber in the current day diet and current day clinical practices. Thank you so much.
Thank you. Thank you very much. So here is the slide. So thank you. So I want first to thank the organizers of this amazing day, Dietetic Day, and giving me the opportunity to be here with you, first time in India. I'm very proud and very honored with this outstanding audience, and be able to share with you some of the science around the importance of fibers in health and disease. And I'm very also pleased to come just after the previous talk, because this is a nice continuum, and you may see things that were eventually looks like redundant, but it's not. It's just a part of the same storyline. So, as indicated in the previous slide, and thank you very much for the very kind introduction. Indeed, one disclosure is that I am an employee of Nestle. That's happened in life also. So I will touch base with essentially 3 chapters. The fiber and microbiome, that is a nice link with the previous talks, how they modify the microbiome and their importance in support of gut functions. And then I will talk about also the use of fibers in enteral nutrition and in specific chronic disease. So I will be short here because it was very, very well and extensively presented before. As you understood, the microbiome is a very complex ecosystem, and it is a key player in the crosstalk with the host. It's a double-side interaction, the response of the host to the microbiome and how the microbiome triggers host functions. This leads to impact on different physiologies and even physiopathologies, and this is why we often speak about microbiome in health and in disease. So the microbiome is a dynamic, if I say an organ. It's a dynamic ecosystem. It evolved with the lifespan, and it is under multiple influences that can be influences from the host as host factors, but also external influences. I have been working before my position at Nestlé Health Science long time with the infants, and particularly on C-section born babies. So yes, this is a typical case where at birth you can have some significant impact on the microbiome. The key modifiers of the microbiome, or the influencers of the microbiome, as previously mentioned, is the diet, medication. We think, of course, of antibiotics, and also environmental factors. among the nutritional, let's say, modifiers, for many years, about more than 30 or 35 years, we learn about prebiotics. So those are dietary fibers that helps to selectively grow some beneficial or health-promoting bacteria, like lactobacilli and bifidobacteria. And also we learn about probiotics, which are live microorganisms. You all know about them, some even much better than me. But the definition of probiotics highlights some key elements. First, the nature is live. It highlights also a certain dose and also a certain specific activity and benefits. And then, most recently, we realized that some microorganism doesn't need to be necessarily live to confer health benefits. And indeed, we realized that by doing some research on, for example, heat-treated commensal strains, even some of them even not probiotics, and we saw that they can have some impacts on diarrhea and other features. So it highlights that finally there are much more components within the probiotic cultures that can be beneficial for the host, and this gave rise to postbiotics. So post is post-life, and biotics is to reference to the probiotics as they were. So it's a preparation of inanimated. So inanimated was to say, not to say heat kill, because it's not necessarily a good word. So it's inanimated microorganisms and or their components. Components could be bacterial fractions, can be metabolites, can be some vitamins, can be all those together in one matrix constitute what we so-called postbiotics. I invited you to consult the ISAP, International Society of Pre- and Probiotics website, where you have many informations on that. I will focus more on fibers, and on dietary fibers. I have here highlighted two recent reviews that summarize quite well the interaction of dietary fibers. Of course, this is my bias because I'm more in pediatrics, so those are both reviews dealing with fibers in pediatrics, but it shows clearly how the fibers can interact with the microbiome, giving rise to short-chain fatty acids that fuel the colonocytes, and this leads, as it was presented just before, in multiple functions, either directly or indirectly through an impact on microbiome. I will get back to this point later. Those fibers, as mentioned before, have a very strong impact on gut health particularly. And talking about gut health, what about the issue? So we can start talking about a more frequent gut issue, which is constipation. Very frequent and very, in fact, damaging, if I can say, the quality of life of the populations. You can have acute constipations or chronic constipations that encompass inadequate bowel movement, hard stools, pain, and so on. And with that respect, the standard procedure or the standard approach or clinical approach to manage is indeed a lifestyle change and diet recommendations that will include more fibers in the diet. And this is coming from back to 2018 on the World Gastroenterology organizations to really recommend more fibers, as you can see, quite substantial amount to treat and to manage constipation. Talking about constipation and gut functions, thinking about fibers, I will go here into one of examples of those dietary fibers, which is partially hydrolyzed guar gum. Guar gum as such has a little bit of a negative perception because it can have some pain and bloating and so on. But here we are talking about partially hydrolyzed. And this is very important because by this approach, we overcome all, let's say, what was potentially, let's say, bad with guar gum. So this is a 100% soluble dietary fiber. It is when it is hydrolyzed, it becomes very simple white powder, very dissolved in water, and importantly that with this hydrolysis you have a breakdown in lower molecular size and also improvement in viscosity, both supporting a better palatability. This structure of PHGG, or partially hydrolyzed guar gum, is much more complex than simple and short-chain, eventually other fibers like phos and inulin. And this complexity, in fact, is a key driver for some functions. Indeed, the branching, the architecture of the molecules is key, and this allows, in fact, a better tolerance, as tested, and I will show you some examples. And also, of course, it leads to a slower, in fact, fermentation. This is important. We know that fast, easy, and fast fermentation lead to bloating. This is exactly the case typically with inulin, that in certain doses, it leads to some bloating. So what we know about how PHGG can work, as I say, with slow fermentation, it has an impact on microbiota. On one side, it leads to production of short-chain fatty acids, particularly butyrate, and this can, on one side, leads to fluid, enhanced fluid and sodium absorptions. Together, it will contribute to normalize the stool. On the other side, it can also accelerate transit time of movement. As I said, it is also fermented by the bacteria. It will increase some health-promoting bacteria. This is reflected by prebiotic effect. And this also constitutes a very interesting element that with the growth of this bacteria, you can have, in fact, increase in stool weight, and this is also supporting a bulking effect. And here, remember this, it has a kind of dual potential, prebiotics in terms of microbiota modification, but also bulking effect. On these fibers, I hope I have shown you, and I will show you now further in more details, that it can support the constipation and regularity and modulation of the microbiome. But importantly, not all fibers are the same, and this is a key element. You cannot transpose one to the other. Or each of them can have a specific benefits. They have their own structure. They have their own interaction with the host. And as you can see, they are not doing all the same job. When it comes to PHGG and some key elements around its use in clinical practice, of course, the first is about tolerance and safety. It has been documented since many years in different situations with different dosing and in different clinical situations. On the prebiotic I talked about, I just here highlight few examples just to, let's say, exemplify my words with some data. And you can see in those studies that consumption of partially hydrolyzed gum in different patients and in different populations, it gave rise to improvement in some of the key bacteria known to be health promoted. But beyond this, relatively on the left side, all studies, you have also, as depicted there, many publications that further highlight this prebiotic effect. I was talking about constipation in general population. What the best to highlight that through a meta-analysis that is the top of the evidence-based medicine pyramid. You can see on this meta-analysis that in doses ranging between 5 to 7 grams per day, PHGG can improve fecal frequency. It can also improve extraction feeling, but also you can see on the right side it can improve moisture. Moisture is important because it's helps to have a better stool forming, and this also contributes to bowel movement and fecal frequency. What about some more let's say clinical conditions like IBS or more chronic constipations? In this case, PHGG also clearly showed in multiple studies that it can reduce constipation. Very interestingly, in IBS, you can see that it can improve GI manifestations like flatulence, bloating, and cramping. So, as I mentioned initially, when you have this constipation, and you know it better than me, you try with diet, with the lifestyle, but also you use laxative. And we have been through different studies and observed that indeed the use of PHGG can reduce the use of laxative. and this was already published a couple of years ago, but also more recently in this paper where in the conclusions they clearly conclude in a long-term setting you have a reduction of constipation and reduction of use of laxative. Now, of course, when you think of these benefits, you also consider the use of fibers in enteral nutrition. Enteral feeding, as you know, is recommended for all patients who cannot achieve their nutritional goal. So you will decide to do either gastrostomy or a nasogastric, depends on the patients, but to feed them and to how to feed them, obviously with some formulas. Those patients, when they are fed with tube, they often experience intolerance to feed. It can be relative to the formula itself, and this is the reason peptide formula are used to, in fact, overcome some intolerance that you can observe with polymeric formulas. But it can also, because of the tube itself, placements, can lead to constipations, eventually even to diarrhea. There was recently this paper from an expert group who clearly acknowledged the importance of fibers in enteral nutrition and recommended indeed its use broadly and more systematically in enteral nutrition. And indeed, along with those lines, you all know about some whey-based peptide semi-elemental formulas. Here it's a formula that was significantly enriched with fiber, PHGG in this case, as I was describing it. So it's a whey-based peptide formula with 12 grams per liter, and the study was conducted in US to test its tolerance and safety, and indeed it concluded on that. But beyond that, it also showed it can reduce constipation. And very interestingly, back to what I was mentioning before, they also observed a substantial reduction of laxative in these patients. This was recently published, and there are actually 2 other studies ongoing on that. Now I want to switch to beyond PHGG, I would say, to other fibers, but also to other trends in enteral nutrition, and speak a little bit about real food and plant-based formula. Those are totally new, and in fact, those children and patients in general under gastrostomy feeding usually get polymeric. In many hospitals and in many practice, they get semi-elemental from first line. This is a regular practice. I just have a meeting recently in Italy. They do it on a systematic basis, and I think in India it's also a practice. But still, parents and caregivers since decades were interested and were advising and advertising to use homemade blenderized food, that they were perceiving that, of course, as more natural. And indeed, along the years, those homemade blenderized food were associated with some very good tolerance. Some also papers refers to change in microbiome, favorable change in microbiome, and perceived as more natural. However, there are also cons with the use of this home blenderized food. First, they are not sterile. There is a risk of contamination when it comes to tube feeding. There is a risk of obstruction because of the viscosity of the product. There is a risk of also inadequacy because not everybody is expert in nutrition like in this room. So of course this kind of therapy requests or require a very careful dietitian's management. And then finally over the years the industry respond to this trend by producing new formulas that are very well designed with ingredients from real food. They can be used as tube feeding or oral feeding, and they can be used in hospital setting or at home. And by the way, recently the UK Dietetic Association acknowledged the benefits of this formula. I will show you a few examples of recent studies done with such formulas containing real food. A study done in Gosh, which is one of the biggest hospitals in London, addressing tolerance and safety, but also efficacy of this formula. Those are patients, 43 patients, most of them in neurologically impaired patients, on tube feeding, and they were under a standard polymeric formula, milk-based, and they start to have some intolerance to feed symptoms. They were switched to this formula with the real food, and indeed, most of them, if not all, improve in GI symptoms, tolerance, and all aspects of, in fact, as indicated, including constipation. Very interestingly, thanks to these good results, now this formula was also, and now in practice, in more critical situations like intensive care and oncology. And I will now show you an example of a recent study just published on the use of this real food-based formula in a pediatric intensive care unit. Those are patients, of course, in PQ, and what in practice they have antibiotics. So the antibiotics alter the microbiome, but also the antibiotic-associated dysbiosis leads to diarrhea. So they have assessed when they put those patients under these enteral feeds, and indeed what they observed first, tolerated, very well safe, they achieved their nutritional goals, but also when they were switched to this formula, high in fiber, delivering 10 grams per liter of fibers, and this is another composition of fibers that is a mix of soluble, insoluble fibers, P fibers, and a combination of phos, inulin, and acacia gum. When they tested that, they as you can see in the figure, the stool frequency and the stool consistency significantly improve. And importantly, when you have this dysbiosis and alteration of the microbiome, one indicator is it affects the short-chain fatty acid production. In these patients with this formula, they could stabilize and avoid this change in short-chain fatty acids. So the very promising data, there is still now another study ongoing to further dig into these findings. Now I will finish the talk with the last chapter, which is about another chronic conditions where dysbiosis and play a major role. Thanks, previously it was very well addressed, so I can go fast. I will talk about Crohn disease. And in Crohn disease, which is part of the manifestation of the IBD, inflammatory bowel disease, it's a multifactorial disease with a genetic component, immune component, and an environmental component, with also, of course, don't forget the diet and dysbiosis. Just an illustration of this dysbiosis that was already presented. You can see a very important shift in the composition with bacteria that are really decreased versus increase in the population with IBD. And since then, many papers highlight the role of diet and lifestyle diet contributions to the risk or to the benefits of the Crohn disease that overall is reflected or is highlighted by or underlined by a loss of diversity and dysbiosis compared to healthy. So very quickly we realized that there were some key components that were described before that can cause, in fact, or can be very high risk for IBD. So the idea was to eliminate them and propose new therapeutic approach, and this is what gave rise to the guidelines from different institutions like ESPEN or ECHO and EBSGAN that put enteral nutrition, exclusive enteral nutrition, as first-line therapy for mild to moderate Crohn disease in pediatrics at this stage. This was an idea to exclude all the bad guys, I would say, and keep this formula. However, if you go deeper into the role of diet on the host and on the microbiome, what you can see, you have on the pink side is the host, and on the blue side is the microbiome. Indeed, many components of nutrition and diet are triggering those effects. And you can see circled in green, in many elements, low fiber is a key player. Indeed, when you look at the practice, and even at ESPEN, in fact, it is recommended to avoid fiber. Of course, I can understand this very conservative approach when you have no clear understanding on the needs, clear understanding on what would be the good fiber. it's indeed better to avoid fibers at induction and then go further. However, having this said, when you have no fiber, you have what you have on the screen. You are affecting the host. So there is a balance there. And indeed, talking about various fibers, this is a very nice work done by a Canadian team, published recently, where they could see that, yes, not all fibers are the same, and some fibers may cause potentially problems. You can see on the graph that FOS, typically very well-known prebiotics, which is working very well on gut health, on healthy situation. But here in this case, in an inflammatory situations, it may exacerbate the inflammatory response. While, if you look at the graph, in a non-active disease, it has no impact. So it highlights what? It shows that according to the condition, according to the situation, the fiber may not react the same or be functioning the same. So I put it in bold. I think in IBD it's not about avoiding fiber. Instead, it's about selecting a good one in appropriate situation. And this is what makes one of the rationale to build up a very well-known now diet, that is Crohn's disease exclusion diet. That was about excluding, let's say, potentially harmful an ingredient that can cause dysbiosis and replacing them with other more healthy food to support microbiome, immunity, and gut barrier. This diet is a whole food diet that is in fact structured to avoid, let's say, harmful food and having more healthy food. As you said before, many of them inspired by Mediterranean diet. It's a multi-phase approach to go from induction to maintenance of remission that include partial enteral nutrition to optimize the nutrition provided to the patients, including energy, calcium, proteins, and micronutrients. So that's why it's combined food and partial enteral nutrition. If you want to learn more, as you have seen, my presentation was all unbranded. This is not branded. I think it's the first time where you can see Nestlé Health Science indicated. I mention it not to infringe the principle, but because this is a free education program that is available to all. So if you want to go to the QR code, you can go and see the training program to learn more about Crohn's disease exclusion diet. Last word on that, because it's making the link with all the storylines so far. Yes, this diet tested in a randomized controlled trial showed that it can support a beneficial effect on the microbiome and overcome the dysbiosis in IBD. Before concluding, just to highlight, this is a key achievement over more than 10 years research in the area. And we saw before that there is much more to come, and one aspect of it is on ulcerative colitis. Thanks to introduce this nice paper. This is the horizon for the future. I show you here a lot has been done on Crohn's disease. This Crohn's disease exclusion diet today is even recommended in the ESPEN guidelines for induction therapy. And very, very recently, just before I come here to India, I came with this paper from the expert consensus paper from Australian team who made a positive statement also for adults, so pediatrics and adults. But then the future also will be certainly around developing diet for ulcerative colitis. My last take-home message, 5 key points. Dietary fibers are essential component to support microbiome and health, balance and health. As I said, not all fibers are the same. You have different structure, different source, different functions, and different benefits. And beyond the use of these fibers in oral nutritional supplements, you can also, and all the data support that, use them in enteral feeding as first-line nutritional therapy. They should be considered for all patients with a special care. So that's why I said careful monitoring. This is important, particularly for fiber-naive patients, where you should introduce fiber gradually and check how they will support them. And at the end, it's not about a very specific and very well thought choice of fibers, at the end who will decide is the patient. So the patients will continue on the fiber he tolerate or she tolerate the best. And long-term feeding, as you mentioned it before in the talk, so I finished with the same almost conclusion. Yes, long-term feeding is to be considered because you will not have an effect on acute system with very few days of feeding, but it's more about long-term benefits. Thank you very much for your attention, and please, if there are any questions, I would be more pleased to answer them.
Thank you, sir. That was a very elaborate discussion on the use of dietary fiber. As clearly highlighted the importance of usage of it in enteral nutrition, careful usage of fiber in cases of ulcerative colitis and Crohn's disease, and also to be very careful in patients who are on an enteral feeding and usage of fiber in long-term cases. Any questions?
One basic question from my side, actually. See, as the industry seems to be divided, actually the nutrition division of the industry seems to be evenly distributing the fiber among the breakfast, lunch and dinner. That's what all the formulas say. But surprisingly, when we start supplementing patients for constipation, I think we give a bolus dose in the night. I'm not sure. I mean, it's totally, I mean, your formulas are very absolutely right because you're distributing the fiber between your 3 feeds. But when we are treating patients for constipation, I think we seems to be giving a bolus dose of fiber. What is your opinion on this?
So, I prefer a gradual introduction. Our experience and the trial I show reflect that. So, we were discussing how much of this whey peptide-based formula with 12 grams per liter of PHGG, how should we administer it? Is it as a sole source of nutrition, one shot, bolus, or, and this is how it works, is to design an algorithm of progression with the volumes, and finally your success will lead to, after 3 days or 4 days, to reach the ultimate caloric goals. But if you start to have a direct full volumes for the patients, I have to say some patients experience some GI symptoms, particularly because they need to adapt to this new regimen. So we need to consider really this notion of adaptation to new regimen. If those patients are patients who are used with fibers, consumers, yes, those are the proportion of patients that works very well for them. But we have to consider the whole population. So we rather propose to go stepwise to reach a maximum benefits on that.
Dr. Jalil, myself, I'm a dietitian from Apollo Hospitals, Hyderabad. The general concept of dysbiosis that we're seeing it even if there is no chronic disease. There is a lot of dysbiosis which we see in the general healthy population as well. So do you have any studies which tell you about a dysbiosed gut? You give this fiber and then after a couple of months, which maybe 3 months or 6 months, you see a significant difference in the gut microbiome, and if so, what would be the dosage of that?
Yeah, so you have two sides on your question. One is the GRAL, that we hope to understand dysbiosis and then make a tailored approach, even with different type of fibers to go along the journey. I hope science will tell us more in the future. What we know is that indeed, let's take different examples. If you have a child that's born by C-section, he has a drop in bifidobacteria typically, and this child, if you bring him with some BMOS or let's say human milk oligosaccharides, you will have a recovery after a couple of weeks, which is around, when I say couple, I mean 2 to 3 months, you see a catch-up. So, and then you can maintain. When you take a patient with IBD, active disease, you have a dysbiosis. You can see it. when you start to treat the patients, we do see that after 6 weeks, more or less, you start to see that the microbiome is kind of recovered. And we know that some fibers are important there. And why? Because if you stop the treatment, after a week or 10 days, you start to see again a change in the microbiome composition. Now, is there a specific knowledge of one target fibers? This is the literature who tells us. So we use what we know. Today we have some examples. I talk about PHGG, we talk about some others. We can talk about pectins, and pectins are very well used, and certainly for the future in ulcerative colitis, this will be a key players to balance the dysbiosis. I hope I have more or less answered to your question, otherwise I can further discuss with you the point.
Yeah, even if there is no chronic disease per se, let's say there is no ulcerative colitis, in a normal healthy individual also, in the general population we see a lot of dysbiosis. So do you see that going away?
Yes.
And how long do you think it takes, if they sincerely take it as per the prescribed regimen, how long do you think, if you test the gut microbiome, these days a lot of labs actually test the gut microbiome and give you a report about how good or bad that is. So
beyond the daily changes that can evolve, if you do a measurements of microbiome every week you will see some slightly different pictures. But what is sustainable when it comes to change in some of the group of population of bacteria, this is very sustainable. It stays for a long time. And if you don't treat it, it stays and it continues to nourish the vicious circle of exacerbating the situation. So we were questioning typically that in the Crohn when it comes to these different phases of remission and flares. And in fact, that came to the notion of how much of real we are when we speak about remission. Is it about deep remission? Is it about sustained and high quality remission? Or is it a kind of a little bit of superficial clinical remission, but in fact the underlying features are still bad? And one of them is the microbiome. The tone of these changes is sometimes controlled, typically with anti-TNF, for example, but very quickly when you have a little disbalance in your life, it raises up and then you go with flare. So it's always there. The tone of it can change, but it's there until you manage it. And this is why the dietary management or nutritional management became so popular and so interesting in this case.
So
There's a question from
how
one of
long
our
do you think it should be given?
It stays, forever, almost,
Until
until the disease is cured. But unfortunately, many of those diseases cannot be cured, so you have to keep a control for them.
Yeah, I'm just trying to understand, is there for the patient to see a visible benefit out of the regimen that you're suggesting, how long do you think it should be given for them to see the benefit? I understand that it can be given for long.
Today, if you think of Crohn disease, yes.
In the interest of the time, actually, we can probably continue the discussion during the tea break. But there is a question from one of our delegates. Please come closer to the mic, ma'am. Please.
No, you are in the microphone. Yeah. I will come back to your question later. Yeah.
After a course of antibiotics, the gut microbiome is disturbed. So how can we restore the gut microbiota through dietary fiber? Actually, many fibers doesn't reduce the side effects of antibiotics.
It's a big challenge indeed. However, first you have to, at certain stage, you have to stop, as it was mentioned before, the excessive antibiotics. And then you talk more about recovery. Yes. But this is the case for fibers, it's the case obviously for probiotics. If you give it concomitantly with antibiotics, you will not see much. You will see some improvement or some balance, but you will not see much because you will have to wait a little bit for the recovery phase and how fast you will recover. The difference you will see is between patients who don't have fiber, stop antibiotics, it will take at least around numbers of weeks before he recover. And the patients who have some support, probiotics, postbiotics, now the data shows that after a couple of days, already the microbiome is catch up. So that's where you can see the effects.
Okay, thank you, sir.
And now we'll break for tea actually. I request all the delegates to come back in 10 minutes. Yeah. Thank you.
I request Dr. G.V. Rao sir to present a memento to Dr. Jalil. I request Dr. Vishwanathan sir to present a memento to Dr. Rupjyoti sir. We will now continue with our scientific sessions. I request Dr. Sairam Reddy sir, Senior Consultant Nephrologist and Kidney Transplant Physician, Director for IgA Nephropathy Center for Innovation, Treatment and Education Consortium, to take over the dais. Dr. Kiran Kumar sir, Senior Consultant, Critical Care Medicine, and Ms. Nagam Alleshwari, Senior Dietitian and Head of the Department, Star Hospitals, to take over the dais and carry forward our next scientific session.
We're starting straight away or after tea? Now, may I request Dr. Rajiv? You can announce the Rajiv's. So you invite Dr. Rajiv onto dais. I will invite him as well as introduce him. Two things. Got it. All right. That's easy. Hi, Kiran. Now, may I invite Dr. Rajiv, Consultant Nephrologist, Division of Nephrology, Kim Sunshine Hospital, Secunderabad. Dr. Rajiv is an International Society of Peritoneal Dialysis Fellow in the past, and he's also a faculty of Society of Renal Nutrition certified courses. He's been a member of Indian Society of Nephrology, Indian Society of Nephrology, Southern Committee, Indian Society of Hemodialysis, as well as Nutrition Society of India. And he's been a General Secretary of Society of Renal Nutrition for quite some time. He's got several publications in national and international journals, and he's authored some stellar chapters in ICMR and IMA publications too. And his areas of interest have been diabetic kidney disease, glomerular disorders, renal nutrition, interventional nephrology, and kidney transplant. Now, may I welcome Dr. Rajiv to give his talk on the probiotics and then gut microbiota and kidney disease. Welcome to AIG, Dr. Rajiv. Please go ahead with your talk.
Yeah, thank you so much, sir, for that introduction. And thank you, Dr. Radha and AIG, for inviting me here for the National Dietetics Day. This talk Actually, gut microbiome in kidney disease, gastroenterologists probably live and breathe this topic every day, but it's a little bit close to science fiction for nephrologists. And it involves reading a lot of very difficult names, names we hope never to read again once we close the book, but we have to live with this now. This is the future. I think we can all agree with this sentiment expressed 2000 years ago. So if I have to encapsulate this talk in maybe one slide, it would be this. There is a bidirectional relationship between CKD and gut dysbiosis. And the more we learn about the way the gut actually functions, we realize what a profound effect it has on CKD. And it's more than just that. So all the traditional factors that are involved in the initiation of CKD as well as the maintenance of CKD, things like diabetes, hypertension, glomerulonephritis, I think I don't have to say anything about that in front of an expert like sir. Nephrolithiasis, all these things we find have some origin in gut dysbiosis, or at least are affected by the gut in some way. And very interestingly, if you see inflammatory bowel disease, you will find that there are a host of diseases that are associated with inflammatory bowel diseases which affect the kidney. Things like IgA nephropathy, things like nephrolithiasis, tubulointerstitial nephritis. All these things very mysteriously are associated with inflammatory bowel disease. So this is the agenda for the talk. So basically I would like to focus on 4 things. One is the mechanisms of CKD progression, and I'll give a small tidbit on how microbiome affects the IgA nephropathy and diabetic nephropathy, and what is the effect of uremic toxins, and especially the bidirectional relationship involved, the effects of the gut microbiome on CKD progression, and finally some novel therapies which we are now looking into these days. Now this is the traditional paradigm of CKD progression. So you have a few diseases. These are multifactorial. They have genetic origins, they have origins in your lifestyle, they have origins in your diet, so many things, immunity. So these are the initiating factors, and these go on to kill your nephrons. And these nephrons, the remaining nephrons, have to adapt, and there are structural and functional changes in these surviving nephrons, and they have to hyperfilter to their job. This leads to increased intraglomerular capillary pressure, and then this leads to further dropout of these remaining nephrons. And if you have to look at it in more detail, so you have all these factors like hyperglycemia, hypertension, immune complexes, for example IgA nephropathy or lupus nephritis, infections. High protein diets, a little bit controversial. The reactive oxygen species which are generated in the later stages of CKD and dialysis, the immune dysfunction, metabolic acidosis, all these things will drive pro-inflammatory factors. They increase pro-fibrotic factors, they activate your renin-angiotensin system, they lead to glomerular sclerosis, they lead to proliferation of mesangial cells and interstitial fibrosis. One of the ways that we know that CKD profoundly affects immunity, and we see this daily, is if you go into dialysis and you actually see the dose of hepatitis B vaccine given to your CKD patients, it's actually twice the dose of patients who don't have CKD. And that tells you that somewhere CKD affects immunity in a profound way. We keep talking about uremic solutes. What exactly are these uremic solutes? So again, these words are a little bit of a mouthful to pronounce, but there are very few that we'll be dealing with in this talk. Broadly, they are divided into small molecular solutes, middle molecular solutes, and protein-bound molecules. These protein-bound molecules are actually small molecules in most cases, but because they are bound to proteins, they are not easily filtered by the failing kidney, and they tend to accumulate. So most of the things we look at are things like urea, trimethylamine, you have indoxyl sulfate, indole 3 acetate, and of course picrosyl sulfate. So as your GFR goes down, these cause important metabolic and pathological effects, And especially dialysis is not very good at removing the middle molecules and protein-bound uremic toxins. And obviously, many of these toxins have origins in diet and with specific amino acids, chiefly tyrosine, tryptophan, L-carnitine, choline, and lysine. Before we go on to this bidirectional relationship between CKD and the gut, is there something that a healthy microbiome is actually doing to maintain a healthy kidney? That's one of the things we need to look at. I'll just give two examples. Your body has serine in two forms, L-serine and D-serine. These are enantiomers, basically mirror images of the same molecule. And very interestingly, on the right, you find that D-serine is very important for vascular health. And this is produced by gut microbiota. And if you have enough D-serine levels, then especially after you undergo procedures like, let's say, a coronary angiogram or a PTCA or bypass surgery, you find that, a healthy gut microbiome actually goes some way towards protecting your kidneys against vascular injury, and especially ischemia reperfusion injury. And of course, short chain fatty acids. I think a lot has been said about this till now. These are produced by fermentation of indigestible carbohydrates, and they have a very important effect on modulating inflammation. They also ameliorate renal fibrosis, and they, especially in cisplatin-induced drug injury, they tend to protect your body against cisplatin-induced drug injury. They increase tubular proliferation, they enhance autophagy. So in general, they are keeping your kidneys healthy in some way. So these are the main renoprotective metabolites that we have among the short chain fatty acids, butyrate, acetate, and propionate. And studies show, that they actually affect most of the markers that we look at when we are examining kidney disease. So things like your creatinine levels, blood urea nitrogen levels. They also reduce inflammation, and especially in hemodialysis patients, they are known to reduce inflammation. And they improve your insulin sensitivity, which again goes some way towards protecting you against diabetic nephropathy. If you have to look at their effect on inflammation in more detail, basically from a healthy gut, you have effects of all these molecules on neutrophils, macrophages, the inflammatory pathways, your TH7 and TH17 and TH1 pathways, and all these things go some way towards, reducing inflammation, preventing your own cells from damaging your kidneys. So, what are the chief players in the gut microbiome that at least we as nephrologists are interested in? As you know, the gut microbiome extends all the way from the mouth to the colon, and in each part of the intestine you have these different organisms, and they all affect different organs in many ways. There is no disease, no subspecialty of internal medicine that is not touched by the gut microbiome these days. But if you look at the kidney, they have roles in all these kidney diseases: chronic kidney disease, acute kidney injury, inflammation, nephrolithiasis, nephropathy, glomerular nephritis, all these conditions. And these are the four main groups of organisms that we are interested in, and they all have slightly different roles. I'm sorry, these are a little bit difficult for me to pronounce. Firmicutes, proteobacteria, acintobacteria, of course, these we know, bacteroides. They inhibit production of pro-inflammatory cytokines. They produce bacteriocins. They help improve nutrient absorption. They maintain the epithelial cells. All these things have knock-on effects down the stream in terms of reducing inflammation that spreads to the whole body from gut inflammation. Coming to your gut microbiome and CKD, which is the meat of this topic, there are differences, as you would expect, between healthy individuals and individuals with CKD in terms of how their gut microbiome is affected. So we'll talk about why this is affected in the first place. But in CKD, you have alterations with increases in things like ruminococcus, enterococcus, Bacteroides alstipes, actinomyces, Escherichia, Shigella, all these things. And there are decreases in other groups of bacteria as well. And as you would expect, all these changes have effects on the way your body deals with inflammation. What mainly happens is that as your urea levels go down in response to a failing kidney, a lot of urea is secreted into finds its way into the gut, and this urea is acted upon by bacteria that produce urease, and this leads to the formation of ammonia, which raises intestinal pH, which damages your intestinal lining, and also because there is decreased filtration of all these other toxins like picresol and other uremic toxins. So you end up with gut and blood milieu which are full of uremic toxins now. So this is basically the gut-kidney axis in CKD. So you have damaged intestinal barrier, reduced tight junction proteins. You have increased uremic toxins. You have reduced smooth-chain fatty acids. You have an altered immune response. You have enhanced inflammation. And there are changes in gut microbiota that continue to engender this process throughout the life of the patient. So if you have a healthy gut, so your healthy gut, if you look on the left, it is digesting your complex carbohydrates, it is synthesizing some vitamins for you, it is protecting your intestinal epithelium, it is involved in the biotransformation of conjugated bile, it is regulating your immune system. But once you have a dysbiotic gut and an impaired gut barrier function, you have two things. One, bacterial endotoxins are now entering your bloodstream. There is also immune dysregulation. Both of these lead to inflammation and infections. And you have accumulation of the uremic toxins described on the bottom right. And in very subtle ways, all of these have different effects on different diseases. Diabetic nephropathy, IgA nephropathy, various glomerulonephritis, even things we traditionally don't associate with the gut microbiome, things like nephrotic syndrome. Especially the protein-bound uremic toxins, the indoxyl sulfate, indole 3 acetic acid, and picresol sulfate, they have a lot of effect on the immune system, especially on the interleukin pathways. So they increase interleukin 1, they damage DNA and ultrastructural features in neutrophils, they increase the production of free radicals, they inhibit interleukin 12, they suppress certain cell lines of B cells, and they activate certain cell lines of B cells. Especially in IgA nephropathy, this has some role. So what effect does this altered gut microbiome have on CKD? So we look at two diseases as examples. IgA nephropathy. If you go into your dialysis unit, you will find that most of the people who are 30 years old or 40 years old who are not diabetic and they are on dialysis, chances are that IgA nephropathy is the cause in them. And we are still in the process of learning about what exactly causes IgA nephropathy, and as of yet we don't have a cure for it. But suffice to say that it is because IgA is produced mainly in the gut lining, and you have an altered IgA molecule here against which B cells produce antibodies, and then these molecules are deposited in the kidney, and then they lead to further effects like proliferation of mesangial cells, damage to the glomeruli, and this ultimately leads to glomerulonephritis and CKD. That in a nutshell is what is IgA nephropathy. But what does this have to do with the gut microbiome? So this is a cartoon of pathogenesis. So there are two aspects to IgA nephropathy. So there is a primary gut inflammation kind of approach, and this has been studied in so-called BAFF mice. So you have an altered immune system that is getting triggered, but there is also now a gut microbiome kind of hypothesis, wherein a combination of diet, infections, all these things are triggering an abnormal response. One is not denying the immune aspect of the primary immune aspect of the response, but all said and done, you are now having an altered molecule that is being targeted by your immune system, and you have IgG antibodies against that, and ultimately these get deposited in your kidney. What are these bacteria? If you look at various papers, you will have various names for these bacteria. But basically, these so-called Saturolaceae and Enterobacteriaceae, these are increased. Certain other phyla are decreased. And this affects the methylation of something called as COSM-C, which is a chaperone, that is, which kind of has a protective role in IgA1 glycosylation. So ultimately, this leads to an increase in IgA1 complexes. This stimulates B cells to produce IgG antibodies. These get deposited in mesangial cells, or rather the mesangium. And ultimately, the primary feature of IgA, which is mesangial proliferation, happens. And then the disease, is set off, and then it has its own course. Because now we know that the gut microbiome is involved in some way, naturally we are interested in finding out if modulating the gut microbiome works in some way. People have tried giving antibiotics, basically rifaximin, and of course probiotics, trying to rebalance the gut microbiome, fecal microbiota transplants. Chinese researchers have come up with some herbal medications that seem to have some small role. Giving short chain fatty acids or polyunsaturated fatty acids, all these things go some way towards restoring your gut health, and people do notice that the features of IgA improve to some extent, especially in terms of proteinuria and stabilization of creatinine. Coming to the other main disease, which is diabetic nephropathy, which is the most common cause of ESRD worldwide. So you have these four traditional aspects of the initiation and maintenance of diabetic nephropathy. So you have hyperglycemia, you have oxidative stress, you have hemodynamic alterations. It's very interesting that most people who are diabetic, if they are not, they tend to become diabetic first and hypertensive later, and the diabetes is actually a cause of the hypertension in many of these patients. And that's because of the hemodynamic alterations that happen, the sodium retention that happens because of the high insulin levels. And diabetes is an inflammatory disease in many ways. If you look at what exactly is happening in terms of gut dysbiosis and inflammation, so basically what you're having is an inhibition of so many of the pathways that are kind of tolerogenic, and an upgradation of so many pathways that are inflammatory. And then these tend to drive proliferation of cells. In diabetes, the glomeruli initially tend to become bigger. We are traditionally taught that in diabetic kidney disease, initially there is an increase in the size of the kidney. So you have all these pathways converging on the glomerulus, and you have increase in matrix, deposition of matrix, you have increase in the cell size, you have glomerular sclerosis. All these things are happening primarily because somewhere the gut dysbiosis is driving inflammation and affecting your immune system. It's not as if these things stop once the person has lost all his kidney function and has gone on for dialysis. These things continue even during hemodialysis and peritoneal dialysis. And the way they do that is, again, there are increases in organisms like Pseudomonas and Enterobacteriaceae, and decreases in lactobacilli and bifidobacteria. But some other things are happening uniquely in your dialysis patients. These patients tend to have recurrent bouts of intestinal ischemia because they may be having intradialytic hypotension. Okay? And your peritoneal dialysis patients may be having gut wall edema. All these things are damaging the intestinal barrier. And these lead to translocation of endotoxins, translocation of bacteria, increase in uremic solutes. And ultimately, whatever you see as a feature of uremia in earlier stages is amplified in ESRD patients. But you also have an increased risk of infections, vascular calcification resulting from this. So finally, the thing which I am least qualified to talk about, which is dietary interventions in CKD. So they kind of encompass a large group of very exciting therapies. Fecal microbiota transplant, I know zilch about it, but there are things like, probiotics, prebiotics, symbiotics, antibiotics, adsorption therapies. All these things have been tried now. And even these need not be related to diet, but these are molecular therapies also that are targeting specific molecules. We'll look at that in detail. So when it comes to diet, with regard to diet modification, a low protein diet does decrease dietary uremic toxin precursors. High fiber diet, this is something that has evolved in the last few years, because most of the things which are high fiber, we are also afraid may be high in potassium or maybe high in phosphorus. But now we realize that the trade-off is more in favor of the high fiber rather than these concerns. We are looking into blocking lipopolysaccharide, which is kind of like an endotoxin. So there are medications like TLR4 antagonists. The adsorption of uremic toxins either by oral absorbents or carbon-based dialyzers, and modulation of renal transporters by medications. All these things have been tried. So small studies show that treatment with prebiotics and probiotics does improve uremia. And if you have an abundance of bifidobacteria and lactobacilli, this does decrease uremic solutes. And diets which are rich in precursors of TMO, like red meat, eggs, choline, all these things, these increase your uremic solutes and decrease GFR. VLPD diets, that is very low protein diets, do increase Acinetobacteria and decrease Proteobacteria. With regard to prebiotics, basically prebiotics, the fermentation of prebiotics will modify your gut bacteria, and these will lead to an increase in bifido and lactobacilli, and they decrease Clostridia, Enterobacteria, and bacteroids. And ultimately, they do decrease your pro-inflammatory cytokines. There have been randomized trials with regard to all these things. And if you see on the right, which is kind of the outcome they have studied, by no means these are hard outcomes. These are all inflammatory markers. These are all, let's say, urea levels or creatinine levels. 2 minutes. Thank you. I'll just rush through these slides. So these are slides on randomized trials on probiotics and symbiotics. There is one randomized trial I would like to look at. This was in around 70 patients. So again, if you see before and after probiotic supplementation, you do notice changes in serum NGAL, which is a marker of tubular injury, and serum cystatin C. And there are decreases in inflammatory markers, but these are not hard outcomes, at least for a nephrologist right now. So in conclusion, restoring gut symbiosis is a novel target of therapy in kidney disease, and the armamentarium that we have right now are high fiber diets, probiotics, prebiotics, symbiotics, adsorbent agents, and fecal microbiota transplants. But we are still not yet in the era where this is hard evidence and you have large RCTs that prove this one way or the other. So I think that should be the next step over the next decade. Thank you so much.
Thank you very much for your insightful talk, Dr. Rajiv. The fact that you're emphasizing on a high fiber diet itself speaks to volumes of your interest and enthusiasm in the field of dietetics and and kidney disease. Not many nephrologists are really aware of this. It was excellent. Indeed, we see a high volume of IgA nephropathy cases in this hospital, considering the GI and liver disease cases. In fact, we're working on a $500,000 NIH grant right now to do a whole genomic sequencing for IgA nephropathy patients, ours being a center of excellence in India. My question to you is, we've never used the probiotics in IgA nephropathy at our center. I just want to take your input on, is there any role for probiotics as a medication for IgA nephropathy cases?
The answer that I have, and it's kind of like a difficult answer for me to give, is I don't have any hard evidence for it, but the way my thinking has evolved is there doesn't seem to be any harm in it right now. And we do know that the gut microbiome is altered in IgA nephropathy in so many causes of CKD. And at least there is enough evidence out there to show that there are small changes in urea, creatine, inflammatory markers. So it's not something that I would ever tell a patient as a primary therapy, but it is something that if the patient asks me what else can I do, that is when then I would probably think of adding a probiotic. But with regard to the first point you made about high fiber diets, actually, again, my thinking kind of evolved again in the last few years regarding that, because we are so afraid of potassium in nephrology. But now we know that 1 molecule of potassium in a fruit is not the same as 1 molecule of potassium in red meat, because the fruit also has substances which make it alkaline, and that alkalinity of fruit, high fiber diets goes some way towards mitigating the risk of whatever hyperkalemia we are afraid of. So nowadays I am a full-fledged high fiber, as long as your potassium is okay, eat fruit kind of nephrologist.
Excellent. Yeah, that makes a lot of sense. So before we wind up, Sujan, we can take a couple of questions. Do you have any questions from here? We can just take a couple of questions. Shiva, yes. Intensivist, please.
Yes, sir. Thank you for that nice talk, sir. I have a basic theoretical doubt, sir. The thing is, CKD patients are immunocompromised. CKD patients are immunocompromised, and we have seen that pre and probiotics can cause gut translocation of bacteria and cause bacteremias. So, would we be taking the risk of actually giving these things? I mean, when we know that there is a potential that these can cause bacteremia in these patients. So, should we take the risk of actually administering pre and probiotics?
Yeah, because you are an intensivist, I'm assuming you're talking about the ICU patient.
Not only in general, I'm talking even about the regular patients as well, because any CKD patient is definitely an immunocompromised
so
patient.
We had this doubt when we were dealing with transplant patients, okay? And we would have transplant patients with diarrhea, and the gastroenterologist would come and write a probiotic, and I would flip out. But the more I looked into it, there are two things. One, there is nowadays a concept called the blood microbiome. We used to think of blood as being sterile, but now we know that the blood is not exactly sterile. The blood too has its own microbiome in some ways. And each critically ill patient is different. I don't think we can generalize like that. But I would say that because in our ICUs, we do use probiotics and other things routinely. We have not come across these organisms showing up in cultures. I don't know if that is your excuse, if that is your...
No, sir. I mean, because we tend to get some referral patients. We have seen, especially somebody who have been administered pre and probiotics for various reasons.
Okay.
Apparently, some guidelines are coming up. Yes, you do administer pre and probiotics along in any critically ill patients. But then what we have found is a couple of cases we have got Bacillus growing in the this thing. In fact, they have come with Bacillus septicemia, bacterial sepsis. So which is, I mean, seeing it, I'm very much afraid, especially because I believe that my immunocompromised patients can get infections.
In that patient, I would presume that patient had a really badly damaged gut. I would not use these things in those cases. But in the patients that I see, CKD patients, for me, gut translocation, intestinal barrier damage to the intestinal barrier happens during dialysis. When they are having episodes of gut ischemia, intradialytic hypotension. In those patients, we don't see these complications.
Yeah, I think that makes sense. Sure, we see a different spectrum of patients in this hospital with a lot of GI disorders. Maybe that cannot be generalized. And they say they see a different spectrum of patients. That's the reason why they're comfortable with giving probiotics in these patients, which we may not be because of the GI problems we see in our cases. Any other questions in the hall? Please.
I may just comment, if you allow me, and maybe correct one word. The bacteremia that you can see is not caused. Is a consequence to the situation of the patients with fully altered barrier functions. And probiotics, as being one of the commensal of the gut, will translocate like any others. They have no genetic background that prevent them to reach the blood. They will be behaving like other bacteria. The only difference is that, as you mentioned, You can control them because you know them, you characterize them, you know how to treat them, eventually to eliminate them, which is not the case for pathogen, like any E. coli or something. We have done some studies in HIV-active patients, and probiotics were not affecting the situation. They were under control, but they were not affecting that. We have also, you can see in the track record, a publication in ICU, in patients tube-fed with ICU with a formula, polymeric formula that contains a combination of lactobacilli and bifidobacteria. It was to check for the safety and tolerance. And indeed, in these pediatric patients, until we follow them until discharge, there was no major issue. So it's a case by case, but fully aligned with your point, under very critical control when it comes to these critical situations.
All right, that's an excellent point. Thank you very much for your time, Dr. Raju. Really appreciate your time taking to come all the way to this hospital and give a nice presentation.
Thank you, sir.
I request the dignitaries to join us for a photo. I request Dr. Sairam sir to present a memento to Dr. Rajiv sir. Sir, a photo, all four of us together. Thank you, doctors. We will move on to our next scientific session. I request the chairpersons, Dr. Shivakumar Reddy sir, Senior Consultant and Director, Critical Care Medicine, Dr. Suresh Babu, Senior Consultant Neurologist and Epileptologist, Ms. Lakshmi Nalan, Chief Dietitian, Kamineni Hospitals, to join us on the dais and introduce our next speaker.
A very good morning to one and all. It's afternoon, right? The last session before your lunch. But anyway, we'll have an excellent session now. The topic is a new era in eating safety by Dr. Smita. She is a BA in Masters in Speech Language Pathology and Audiology. She has a PhD in voice and swallowing in head and neck cancers, and she is certified by various by FES and esophageal puncture, laryngotomy, and vital stim. And also, she is a founder and lead of the speech and swallow services at Muzumdar Shah Medical Cancer Center and Narayana Institute of Cardiac Center. She is also having multiple awards and achievements to her credit. And ma'am, I wish you to take over this podium and then explain us about what can we do new in the swallowing disorders.
Thank you for that introduction. At the outset, I'd like to thank Dr. Radha Reddy, who's someone I've really been inspired with after I've met her, and AIG for giving me this opportunity to speak to you about something I'm very passionate about. So the topic given to me today is the new era of eating safety. As I'm a speech and swallow pathologist, I'll modify it to the new era of swallowing safety. Okay, this is the institution I come from, Narayana Health City, Bangalore, which is a multi-super specialty hospital, and we work across age groups and across specialities in speech and swallowing. So the topic ma'am wanted me to cover today is to, just give you a case scenario so you can pick up where exactly a speech pathologist could be referred, and what is swallowing, what are the signs and symptoms, and as a dietitian, when can you or other medical professionals refer patients to us? So let's look at this case scenario. I won't be focusing on the medical part of it. I would just be focusing on how the story changes when the swallowing problems are not picked up. So this is a patient hospitalized in August with decreased responsiveness. She's stable on arrival. MRI shows some infarcts. Okay. She's treated for her stroke. She's discharged on a Ryle's tube, but the problems diagnosed are stroke, hypertension, hypothyroidism, and a delusional disorder. So at the time of discharge, she was refusing to take oral feeds, intermittent drowsiness, and intermittent cough. She gets discharged, and the advice given is continue NG plus oral feeds. She gets readmitted to hospital very soon, and she lives in a nursing home where she pulled out her Ryle's tube and she was fed orally. So she comes back, and again, the diagnosis is aspiration pneumonia. She's treated, the NG is placed, again she's fed orally. Okay. She has multiple problems for which she is treated. Again, she is diagnosed with aspiration pneumonia. Okay. And finally, she succumbs and she does not survive. Okay. So this is a case of stroke. So here the speech language pathologist should have been referred to within the first 24 hours. The current mandate for stroke is within 24 hours. A swallowing assessment has to be done. The safety of swallow has to be decided, and what is the route of administration of food, liquid, and medicine has to be recommended. Okay, so this is how you pick it up at the right time. Now, another thing is the person has a delusional disorder and decreased responsiveness. So the person is going to be drowsy most of the day and awake sometimes. So when is the right time to feed? What is the right thing to feed? This is something an SLP can help you with. Moving on to the next patient, a patient with head and neck cancer, change in voice and change in difficulty with solids for 2 months. Okay, so endoscopy showed a growth in the pharynx, T3 carcinoma. Patient was restricted by himself to a semi-solid diet, and he had discomfort with swallowing solids, so he moved to a semi-solid diet on his own. So the plan was 66 gray, 33 fractions, but after 10 fractions, because of severe discomfort, the patient was not able to swallow liquids at all. So the treatment had to be stopped, NG was placed, patient was nil per oral and admitted into hospital. Okay. A week later, the patient got better. So they restarted oral feeding, and once they restarted, you saw that the patient developed aspiration pneumonia. Okay, and then was tracheostomized. So for an SLP, this is a very shocking situation. Okay, T3 pharynx, the patient should have been referred to a speech and swallowing pathologist, even when the diagnosis was being made. So we would have done a routine swallowing evaluation using a fiber optic endoscope, analyze the anatomy, analyzing the swallowing problem before the cancer treatment starts, and then predict whether this patient should need a tube before you even start. What are the prophylactic swallowing therapy exercises which should be given, and how we can keep a safe swallow going during the treatment, how often they should see us, it is once a week, and then discuss with the primary team members whether an elective tracheostomy is needed rather than this where there was an emergency tracheostomy and the patient had to stop the treatment, which should not happen, okay, as much as possible. So these are two stories which tell you why swallowing is so dangerous and important. Okay, so it increases mortality, okay, morbidity. It definitely increases your beds in the ICU. Our intensivists keep telling us, "Mujhe bed chahiye." This is prime real estate. When are you taking this patient out of my ICU into the ward? The ward doctors are telling me that is prime real estate. When are you giving me the ward bed, right? So dysphagia, malnutrition, dehydration, okay, what it does is it can prevent patients from continuing treatment. It can disrupt the administration of medicine, which again affects the primary problems. And another thing is oral hygiene in patients who with swallowing problem can be affected, which in turn has now been one of the major factors of aspiration pneumonia. So what is swallowing? It is the act a continuous process of food, liquid, solids, saliva moving from the lips right up to the stomach. It's very complex as it involves 5 cranial nerves and 22 muscle groups. So here we have the swallowing which should be safe. What is a safe swallow? Where these things should not enter the windpipe and to the lungs, okay? It can be anterograde, that is from the mouth, it should not go into the lungs. It can be retrograde, that is when a patient vomits or a patient has reflux, that too should not enter the lungs. So our responsibility is protecting the lung from any of these material. So you have 4 phases of swallow, okay, which is the oral preparatory phase, the oral propulsion phase, the pharyngeal and the esophageal phases. Now in the oral preparatory phase, what happens is the bolus is placed into the mouth, and that is what we call as feeding. So in pediatrics, feeding is extremely important. What is the posture? How do you place the bolus into the mouth? Is it breastfeeding? Is it bottle feeding? Is it a spoon? Is it a cup? Okay. How do you place the bolus? How much bolus? Does the patient have good articulatory function where the patient is able to chew, prepare the bolus? Does the patient have a good tongue to propulse the bolus from the anterior oral cavity into the pharynx? Okay. And then you have the second phase, which is the transit phase, during which you should not have any spillage or any nasal regurgitation. The third and the most important phase is the laryngeal phase, in which the vocal cords are supposed to close and the esophagus has to open so that the bolus moves into the esophagus. And finally, the esophageal phase, where you have peristaltic movement and you have passage of bolus from the upper esophageal sphincter into the stomach. So you can watch this video.
Pharyngeal and esophageal stages. At the start of a swallow, a food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent food entry into respiratory passageways. The uvula contracts, which blocks the nasal passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis swings down upon the closed glottis.
So this explains the swallowing safety mechanism, which happens every time you swallow your saliva, every time you eat or drink. So within few seconds, the safety has to be performed, and there should be no compromise during your process of feeding. Even though you may be looking at your mobile, you may be studying, you may be thinking. So even though there is diversion of attention, this safety mechanism has to take place. Now, what are the common symptoms of dysphagia? This is something which is very important so that you can pick up the problems and refer to us. So it can be difficulty, which is dysphagia. It can be pain while swallowing, or dinophagia. It can be globus, a feeling of food getting stuck in the throat. You can have secondary complaints like the patient is eating less. You can have patients with recurrent chest infections, that's how the referrals come to us from pulmonology. And you can also have a very long duration of feeding, or patients complaining that food is stuck somewhere in the throat or chest or even near the stomach. Also complaints of heartburn or chest burn, which may indicate reflux. Now it is multifactorial, so each patient can have more than one symptom which can be causing swallowing problems. Now when the primary problem itself is affecting swallowing, like a stroke or a head and neck cancer, then this patient is admitted into the ICU and then intubated. So then post-extubation, you can have physical trauma to the larynx which can contribute to these problems. And then if the patient has any other problems, you will have to analyze them separately and see how these problems affect the swallowing mechanism of the patient. So as you all know, it's very complex because it starts at the lip, it ends at the stomach. you have to prevent it from reaching the chest, and you also have the brain, which provides the controls. So depending on the problem, you have all these team members who actually help to detect, assess, and manage those. Now, who are we in this whole story? So I had a dietitian at one conference who said, who's an SLP, who's a SALT, who are deglutologists, okay? So we are speech language pathologists who have a base degree with audiology as well. We super specialize to study swallowing because it is the same structures, but the controls are in different areas of the brain. So we use the word deglutology because this is the science of the study of swallowing. So we train and also specialize in the assessment and diagnosis of swallowing disorders using techniques like fiber optic endoscopy or fluoroscopic techniques to detect and manage these patients safely. Now, what should a dietitian do to pick up and help us manage these problems? Okay, the first is you may walk into the ward and your patient is eating. So just observing how the patient eats or the patient is fed gives you a lot of problems which you can pick up. The other thing is just interviewing the patient and asking them about their symptoms and their problems. As you all know, it can change in acute care, it can change from morning to afternoon. It can change over time. It can change based on what food is fed to them. Okay, discuss with the other health professionals. They will give you different indicators, probably based on a syndrome or what medical problem the patient has, which you have overlooked. You can look and further evaluate. Next is whether you need to modify the consistency based on what the speech language pathologist has recommended. Next, the posture and position is very important. So this 90-degree angle of the oral cavity and larynx should be maintained. Okay. Emergency preparedness. If the patient does aspirate, what would you do? Okay, depending on whether the patient has a tracheostomy tube, a cuff inflation, suctioning has to be done. How do you administer oxygen and protect the airway? Okay, how do you monitor the progress of the patient with what diet has been, what consistencies have been recommended? How do you manage the nutrition with that consistency? And educate and follow up with the patients, especially have a backup plan if you're discharging the patient, because as you know, many of the patients get irritated and just pull out the Ryle's tube, right? So what's your backup plan for feeding? So there's a lot of literature which looks at role of dietitians in dysphagia screening. So here your goal is to identify who are the patients at risk, make suitable recommendations to the SLB. And why our SLP is better is because we have learned how to assess, manage, and diagnose. So once you refer the patient to us, we will examine them in detail, all the 4 phases of swallowing, okay, and make suitable diet and recommendations. How would you do it? History, questioning, and mealtime observations. And the risk factors are age, history of dysphagia, which you can pick up, difficulty in solids, liquids, taking medicines, and even with saliva. Patients who have facial weakness, change in voice quality after they eat or swallow, and self-reported measures like drooling of liquids, spillage of food, facial weakness, pocketing of food in the mouth, and prolonged eating time have been red flags for swallowing problems. So here you see different recommendations here for dietitians. So if you observe choking, aspiration, change in voice, these patients you can refer to an SLP. There are multiple competencies which you can train for, and this will help you assess and refer the patient. So here there are some terminologies which you need to know. Now, there are 2 important words you will find us SLPs using. One is penetration. Penetration is when the bolus enters the larynx from the level of the epiglottis to the level of the vocal cords. That's when, if you cough well, that bolus will not be aspirated. But if you have a weak cough reflex or absent sensations in the larynx, that bolus can be aspirated, and that in due course can lead to aspiration pneumonia. Choking is when a patient has this aspiration episode and the breathing gets affected, and then these other terminologies which we discussed. So the incidence depends on what kind of problem. So if you're in an ICU, if you're in a neurology, neuroscience setup, if you're in a cardiology setup, so based on what setup you are, you should know what kind of problems you will be seeing in your clientele and which one of them can have more dysphagia compared to the other. So here this is an algorithm of when you can refer the patient. Okay, so if the patient is not able to handle their own secretions, that is the biggest red flag. There we have to stop feeding, and their prevention of aspiration of their own secretions is the main mandate. So there the goal will be prevention of aspiration pneumonia of their own secretions and oral health. Okay, so if they are feeding, if they are not feeding, based on different time sets, you can refer to an SLP. Now here, these are the different things to consider. So if they are awake, alert, if they are drowsy, if they are agitated, pulling out the tube, okay, if they have any surgery where because of the sutures you cannot feed orally, like head and neck. So the first 10 days you have to manage the nutrition on tube till you start. So you can have surgical causes, you can have non-surgical causes, you can have medical causes, and the most challenging is the psychological causes. So if you have a patient where everything is okay and they have psychogenic dysphagia, or they say, I don't like this food, I don't have appetite, when I look at this hospital food, I don't feel like eating it, right? So it's multifactorial, and when you spend time with the patient and assess them, you break it down and then you can assess and try. Now we as SLPs, we follow these different steps in our assessment: case history, clinical swallow evaluation, and during that we make a hypothesis based on what we want to examine during feeding, and the third part is the feeding observation. So once we decide what problems we see clinically, then we choose which swallowing instrument is better to detect the problem for that patient. So is it a FEES or a fluoroscopy? Now why do we need to do instrumental assessments? Because there is something called as silent aspiration, where in the larynx there is no sensation. So patients can aspirate without coughing and choking. So you may see the patient eating, there'll be no signs and symptoms, and after some time you realize the patient has landed up on it with an aspiration pneumonia. So therefore once we assess the patient, we would do an instrumental assessment if required to confirm the problems. So two things: one is the safe swallow, and if you know in neurological patients, liquid swallows are the most challenging. So to bypass or to minimize the problem caused by liquids, you have thickeners available which have really changed the game in swallowing safety. So based on the ITSE framework, which is the International Diet Standardization Framework, you have 7 classifications of liquid and solid. So from 0, which is water thin, and 7, which is a normal dry solid, we SLPs assess all the consistencies, 7 consistencies, and see if the patient is able to eat which consistently, safely and efficiently. Now efficiency depends on whether the food they are taking in actually reaches the stomach, or there is a lot of bolus collection and wastage of food, and whether they are taking a very long time that the other daily life activities are affected. So this is how we assess the safety. We do different assessments and we use scales to tell you where exactly the bolus has reached and what is the risk factor. This is how we assess efficiency, to see how the food is getting stuck. So you may be feeding from outside, but inside you have a lot of collection of food which later on the patient may aspirate. So this can happen at the level of the vallecula or at the level of the piriform, which is an even more dangerous area close to the airway. So we quantify the residue, and based on it we work on swallowing techniques to reduce these problems. So in the ICU, this is a wonderful article you can read on understanding the mechanisms of dysphagia. And these are multiple signs and symptoms you can pick up in an ICU. In cancer, you can understand the site and the stage of the problem, what kind of treatment. If it's surgical, then you have different swallowing problems. If you have chemoradiation, then you have problems because the normal and the affected cells are targeted during treatment, and then you see them before, during, and after treatment. And these are some of the problems which can be seen due to chemoradiation. And finally, pediatrics, which is a totally different ballgame. Here you need to understand the interplay of behavioral, sensory, and physiological problems with children with swallowing problems. So finally, my take-home message, dysphagia is multifactorial. You need a huge team to even pick it up and assess, diagnose, and manage them so that the patient can prevent malnutrition and dehydration. So timely references to the SLP team will really prevent all the complications which can be led to because of dysphagia. Thank you.
Thank you, ma'am. Very wonderful presentation, because as a neurologist, we will see lot of aspiration pneumonia because of the mismanagement of the swallowing technique. And we commonly see it is a very difficult in a old age group, even though there is no structural pathology or there is no a infarct or there is no structural pathology, but people come with the simple sepsis and they have a difficulty in swallowing. It takes very longer time for them to improve and to convince the patient that you need to be on a Ryle's tube for the more than a month in some people. And lot of neurodegenerative diseases also, even though there is no specific reason, but their swallowing muscles and they will not improve as quickly as the other muscles. And it is a very difficult, I think your help in assessing and modulating the swallowing will really helps, and it prevents the lot of aspiration and the subsequent complications. The longer duration of the stay in neurology patients, at least 20 to 30% were maybe related to the swallowing, a technique default or the something related to the swallowing. Thank you, ma'am. And I think if the people understand the importance of the swallowing, we can prevent so many complications.
It's so important to refer to us. I think in our profession, we are training a lot of people to handle, assess, and manage dysphagia. But when I go to a lot of conferences, I find the primary team members itself are not sure when to assess. So sometimes you need to refer before the treatment even starts, because we can counsel them. We can tell them what kind of dysphagia they can expect and when is the right time to meet us. And then even post-discharge and follow-up, from the ICU, you will discharge them to the ward, but we will follow them up even once they go home and then they come back.
Ma'am, one thing about critically ill patients, they definitely have, this is the deglutition process itself is dynamic. And then thing is, though we might have discharged the patient at a place where probably the patient is able to swallow at a time, but then in the ward, sometimes probably the patient might not be completely evaluated, and probably that is where the dietetics department comes. Okay, can assess the patient on a daily basis and then decide when to refer the SLP, because that is where we lose many patients, where we have this incidents happening. So I think the dietetics department can contribute in a large way to prevent these incidences from occurring, because physicians tend to overlook all these small nitty-gritties, but then when the dietetics department, especially when they are giving the oral, the enteral nutrition through the oral route, then probably they can always assess it as the parameter or the scale which you have given. In that way, I think we can avoid a lot of incidents which help the patients in a long way. Thank you, ma'am.
Thank you.
As you said, it is very true, sir. By day-to-day monitoring, we can do a team effort with neurologist and speech therapist, and we have to, we should assess the patient, and the next step what to do as a combined effort we can discuss and we can do it. And lot of patients by regular follow-up also till they recover, it's very much important, and As you said, we should assess the patient properly. If they're at risk, we should follow with the speech and language pathologist. And as a dietitian, we should monitor regularly, and how to deliver the nutrients in a proper way, we should follow with as a team with the neurologist as well. And till they become stable, no? So we should do the follow-ups. That's important. Like, yeah.
The
And
challenge
modifying
is
the diet.
usually when you have a combined diet. So for the dietitians, if it's only NG or only tube is easy, only oral is easy. Now we go there, every day we're testing 7 consistencies. So what happens is with the primary NG, we also start with oral feeds. So that's our responsibility as SLPs to coordinate with the dietitian and tell them how much oral is allowed, and then that much can be planned.
Okay, ma'am, thank you. If we don't have any doubts, I think there's one question from the pan. Yeah.
Hello, ma'am. Ma'am, I'm a dietitian working at Deccan Hospital, Sumajiguda. Yesterday, I just came across a case where the patient is not eating since past 2 weeks. And according to diagnosis and everything was normal, ma'am, nothing. Only it was rheumatoid arthritis, and she was hepatitis B positive. And as she was constantly complaining ki she feels like eating, but she's unable to eat, and they are from the northeast part of the India. And the doctors along with me, we were counseling the patient, and the colonoscopy was done, endoscopy was done. Everything seems to be normal. So in this case, I was blank to how can I help her? Like, I asked her to take liquid, she's like, I don't want to take it. Then if I'm asking her what you want to eat, should I introduce something? She's like, I want to eat, but as soon as I eat, not only the patient, that the daughters of the patient were like, her tummy is hard. The doctor is counseling, but nothing was being done, ma'am. So at this point, should I ask, along with the doctor's advice, should I ask them to consult an SLP? Or?
Yes, definitely. So when you refer to us here, there are 2 things. One is 2 weeks the patient hasn't eaten. Okay. So that's one area we're going to work with the dietitian. The most important thing is, does this patient have a safe swallow, and can we start oral feeding, and why is she not eating orally? So that's what we will assess and get back to you. If she doesn't eat orally, we'll have to put in a tube then, because 2 weeks are already over.
Okay. Thank you, ma'am. In view of paucity of time, I think we shall conclude the session. Thank you, ma'am. Thank you for the wonderful lecture.
I request the dignitaries to join us for a photograph. I request Suresh sir to present a memento to Dr. Karen. Thank you, doctors. Now we will move on to the most interesting session of the day, the Nutri Quiz. I welcome Dr. Meena Patinge, Dean, HOD of St. Anne's College, Ms. Uruja Biris, Associate Professor, St. Anne's College, Dr. Kushbu Vyas, Assistant Professor, some from St. Anne's College, and Ms. Priyadarshini, Practicing Dietitian from KIMS Kondapur. I request the participants to take over the dais. Team 1 would be from St. Anne's College and PG College for Women, Ms. Maheen Sultana, Saida Aisha, Zoha, Saida Usman Nikhit, Saida Nazish. Can we have you on the stage? Team 2 from Medina Degree and PG College for Women, Asma, Ms. Bibi Mariam, Ms. Sophia, Ms. Batul, Ms. Fatima Mahnas.
Good afternoon, all the best. Come on, don't be nervous, be confident. All the best, good afternoon. Go, go, go. Take your seats in the front. Come on, calm down. See, I'm just going to give a few brief lines and then hand it over to you. So you people can stand there at the dais, no? Both of you, and one by one. Ask Radha ma'am if Priyadarshini is there. May I call all the other teams, rest of the 3 teams to come forward, please? The total number of 25 participants, 5 each from 5
Team
colleges.
Team 3. Team 3, Akshara Degree and PG College for Women, Ms. Renu Shri, Ms. Nurain, Ms. Sumaya Fatima, Ms. Salma, Ms. Sultana. Team 4 from St. Joseph's Degree and PG College for Women, Ms. Samreen, Ms. Shweta Shinde, Ms. Maheen Begum, Ms. Saida Sumaya Ahmed, Ms. Shaista Farhat. Team 5 from St. Francis College for Women, Ms. Sakina, Ms. Pujaista, Ms. Nimra, Ms. Bhavna and Ms. Bhargavi. Meena ma'am as well.
I hope all the participants have taken their respective places. Okay.
Participants, the questions will be displayed behind you in the PowerPoint. Sorry, the participants, you'll be able to see the questions in front of you. There'll be 2 PowerPoints stored over here. It'll be visible for you, and the audience can view the questions in the dais.
नहीं रखो, बीच में ही रखो, थोड़ा ऐसा रखो, ऐसा बैठ जाओ थोड़ा। So, good afternoon, everyone, and congratulations to AIG Hospitals Dietetics Department, Dr. Radha and her team for organizing such a great event on a very, very significant day. And especially including Nutri-Quiz as part of these celebrations, which gives a chance for the students to come here not only to attend the various sessions which add to their knowledge base, but also this particular quiz helps them to know where they stand and how much more they can need to go further to learn about their subject. So without much ado, let's start. And we have Dr. Khushbu and Ms. Uruja from St. Anne's College. They are the assistant professors who are the quiz masters for today. And they are the brain behind today's questions. Questions which come from the subjects which we expect the students to know about. So let's go forward. I hand it over to the quiz masters.
Good afternoon, everyone. I'm Dr. Khushbu, Assistant Professor from St. Anne's College for Women, Mehdi. So we are the quiz masters for today, and I wish all of you all the very best to all the 5 teams. And this is going to be a very interesting game for all of us today. So I'll hand it over to Uruja ma'am.
Hello, good afternoon, everyone. My name is Uruja, an Assistant Professor in Department of Nutrition, St. Anne's College. So let us begin without further delay. So we are going to basically have 3 rounds for today's quiz competition. So round 1 is going to be a rapid fire. Round 2 is a multiple choice based question. And round 3 will be a visual round. So let us begin. Before we begin the round 1, I'm going to just talk about or introduce you to the rules for this round. Each team has to expand the clinical abbreviation, and you will be given 3 seconds to answer. The question will be passed on to the next team if that particular team doesn't answer. Each question carries 5 points. If the question is passed, it will be given, the next team will be given the 3 points. All right, I hope the rules are clear to all the 5 teams. Yes. So the first question goes to Team A. What is the full form of CRP? Your time is running out. The question passes on to Team B.
C-reactive proteins.
Good, correct answer. Team B gets 3 points. Now, same Team B gets the second question because that was the bonus. The abbreviation that you'll have to answer is LRTI.
Lower respiratory tract infection.
Very good. Correct answer. Lower respiratory tract infection. Now, Team C, be ready. CABG.
Coronary artery bypass grafting.
Yes, correct. Coronary artery bypass graft. I request all the audience, please not to do prompting or any kind of whispering, please. Let the team answer. Now the question is for Team D. COPD.
Coronary obstructive pulmonary disease.
That's a correct answer. Chronic obstructive pulmonary disease. Okay. Yeah. So it is wrong. Then the question passes on to Team E. SGA.
Serum glutamic aminotransferase.
Time up. You have delayed in answering and wrong answer. So this is, we have come to the, they have already told. Okay. Yeah, so the question passes on to team A.
Subjective global assessment.
That's the correct answer. To team A gets a bonus point. Now again, team A, the next question for you is PES. Time is up. The question passes on to team B. Team C. Yes. Team D. Team E. D, time is up. Your time is up. Please pass on the mic to team E. The answer is problem etiology, signs and symptoms. Now the question comes back to, the next question is for team A. What is GLIM? Team B, the question is passed to team B. Then to team C. Team D. Team D. Now team E. Time is up. The answer for GLIM is Global Leadership Initiative on Malnutrition. The next question passes on to team A.
No, ma'am, actually.
It passes on, team A. The question is SIRS. Passes on to team B.
Systematic inflammation response syndrome.
Can you repeat?
Systematic inflammatory response syndrome.
It is systemic inflammatory response syndrome. Systemic. It's a wrong answer. Team C. ESRD.
End-stage renal disease.
That's the correct answer. Team D. NPO. The time is up for them. Team D, time is up.
It's already up actually.
Team E, the question passes on to Team E. NPO. Time is up. So by this we have come to the... Okay, Team A. Take the mic, please. The question is passed on to Team A.
Nil per oral.
Very good. They get, that's the correct answer, nil per oral. So with this, we have come to the end of round 1. I request Khushbu to take over the round 2.
Okay, we move on to round 2, which is a multiple choice questions. So the rules for this round will be, each team to choose the best answer. 5 seconds will be given to answer, and question will pass to next team if unanswered, and 3 points will be given to the past questions. Okay? So you are all ready? Okay. So first question for team A. Which of the following hormone is an appetite suppressant? Which of the following hormone is an appetite suppressant?
Leptin.
Okay. Yes, this answer is correct. All the teams are requested. The questions are displayed there on the screen in front of you. So you can see from there, okay? So now the next question is for team B. Kidneys help in regulating blood pressure by secreting dash. The options are there. Team B.
Angiotensin.
No. Next, team C. Give the mic. Okay, next team. Team D.
Sodium and potassium.
No, wrong. Team E.
Aldosterone.
Wrong. Okay, girls. So the correct answer is renin. Okay, we'll move to next question. This is for team C. So the third question is, yes, girls, I request audience to please maintain silence. Hypoglycemia is a condition where blood glucose falls below
70 mg per dl.
Correct. 70 milligram per deciliter. Moving to next team, team D, we have the fourth question for them. What is the correct order of steps in nutrition care process, NCP? Okay, I'll read the options. Assessment, intervention, monitoring, and outcome evaluation, diagnosis. B, diagnosis, assessment, intervention, monitoring, and outcomes evaluation. C, intervention, assessment, diagnosis, monitoring, and outcome evaluation. And D, assessment, diagnosis, intervention, monitoring, and outcome evaluation. Which is the correct answer?
D.
Yes, D is the correct answer. Now the next question is for team E. For short-term feeding, the most commonly used method is
B. Nasogastric tube.
yes, this is the correct answer. B, nasogastric tube. Please pass on the mic to team A. Fifth question. Now I'm asking sixth question. Quickly pass the mic to team A. Okay. The question for you is, ketogenic diet is prescribed to patients in which neurological disorder?
Epilepsy.
Time over. Okay.
Can we consider?
Okay. ठीक है. It's the right answer. Next question. The question is for team B. ACE, the angiotensin converting enzyme, is synthesized by?
Liver.
No, wrong answer. Pass.
D. Lungs.
Yes, lungs is the correct answer. Team C. Again, the question will be asked to them. Now, this question is for team C. Long periods of exclusive parenteral nutrition are not recommended because, I'll read out the options. A, it increases the toxicity of blood. B, it puts pressure on the kidneys. C, it puts pressure on the heart. D, it causes atrophy of the GI tract.
Ma'am, D.
Yes, D is the correct answer. Now, the question is for team D. In case of renal insufficiency, what is the composition of proteins recommended?
C.
Yes, C is the right answer. And the question for team E. Indirect calorimetry is the golden standard for the measurement of energy expenditure. True or false?
True.
Yes, true. Correct answer. So we have come with the end of this round 2. Now we'll start with round 3.
Round 3 is the visual round. The rules for the round, this round goes like this. Each image So we are going to display an image which represents a clinical condition. You will have to identify and name the clinical condition. 5 seconds will be given for each question. The question will be passed on to the next team if unanswered or if the answer is incorrect. And each question carries 5 points. If the question is passed, it will be given 3 points. So the first question is for team A. Identify the clinical condition.
Acanthosis nigricans.
Good. Correct answer. Acanthosis nigricans. Team B. Identify the disease condition.
Kwashiorkor.
Wrong answer. Team C.
Ascites.
Correct answer. Or, yeah, which is seen, it's a clinical condition in cirrhosis of liver. Team C. Identify the device.
Dialysis.
Pass it on.
Dialysis.
Yes, it's the correct answer. Dialysis machine. Yes.
Now team D.
E. Identify the clinical presentation.
Brittle nails.
Wrong answer. Team E.
Koilonychia.
Correct. Correct answer. Spoon-shaped nails or koilonychia. The question for team E again. Identify the equipment. Time up. Team A. The question passes on to team A. Team B. Team C. Team D.
Hand strength machine.
Team E. The answer is hand grip dynamometer. Team A. The question is for team A. Identify the equipment. Team B. Time is up. Team C.
Pacemaker.
Team D.
ECG machine.
Wrong. Team E.
VO2 max measurement.
Can you be louder?
VO2 max measurement.
Wrong answer. Anybody from the audience? They have already. Anybody from the audience? Can you be louder?
Somebody raised the hand in the last row.
Yes, that's correct. Bioimpedance analysis, or also called as body composition analysis.
Yes, ma'am. Team A.
Team A, identify the condition.
Goiter.
Right answer. Right answer.
Correct. That's the correct answer, goiter. Then team B, identify the condition. Team C,
Marasmus. This is wrong.
you'll have to be more specific. Team D.
Marasmic kwashiorkor.
Okay, we can consider it is actually protein energy malnutrition or muscle loss. So it is a PEM, so we can consider.
Team B's question.
Now the question has to go to team B. Now question is for team E. Identify the route of nutrition support.
Nasogastric.
Yes, that is correct. Enteral nutrition or tube feeding or nasogastric feeding. Now team A. Last question. Identify the clinical condition and mention the nutrient deficiency.
Cirrhosis.
Wrong. Team B. Team B, quickly.
Ankylostomatitis.
The deficiency of nutrient also you'll have to tell.
Vitamin C.
Wrong.
Sorry, B2. Vitamin
Wrong.
B2.
Next.
Vitamin B2.
Yes, correct. Half. That marks the end of round 3. I would like to thank all the participants for their enthusiastic participation. The results will be declared shortly.
So we would like to thank you, Radha ma'am, for this Nutri-Quiz, and it has really brought a lot of enthusiasm to the students. Thank you so much and congratulations.
Yeah, we had in fact a lot of fun while we were framing these questions. So we were thinking from the students' perspective that what knowledge that they have and how to frame these questions. So I would really like to thank ma'am, Dr. Meena Patange, our head of the department, Department of Nutrition, St. Anne's College, and Radha ma'am for giving us this wonderful opportunity. Thank you.
I request Dr. Radha ma'am to present the final scores and declare the winners. I request Dr. Meena ma'am to stay on the dais and distribute the winners their prizes.
I know we are waiting for the lunch, but we'll just finish this interesting session and who are the winners for the quiz. This is something that's very encouraging, and we would want to involve more students in such activities because it's a learning place. So the runners-up goes to team 1, who has scored 26. Which college? It's from St. Anne's College. 5 of you. Read the names.
Miss Maheen Sultana, Saida Aisha Tazeen, Miss Zoha, Miss Saida Usman, Miss Saida Usman Nikit, Miss Saida Nasir Husaini. Please come to the stage.
Okay. Yeah.
So team A is the runner-up now.
Who's team 1, girls? From which college is this? Okay, sorry, please, St. Joseph's. Please come.
St. Joseph's Degree in PG College for Women, Miss Sheikh Kansa Samreen, Miss Shweta, Miss Maheen Begum, Miss Saida Sumaya, Miss Shayista Farhad.
It's something that, AIG is a place where we always want to learn and pass on to the next generation. So as winners, we thought we will not give them the regular prizes, but then what we will actually give is this book, which will actually help you all as a reference for all your medical nutrition requirements. Okay? So each of the winners will get this book as a token of appreciation. Thank you.
Yes, they have something like this, ulta reverse. Team A has sat there.
Go. All of them, each one a bag. Congratulations. Please, both of you come. Take a group photo, please, with the runners-up team. Stand that side. Thank you. Okay, now the final team, which is actually, we had 2 prizes. One is the winner and one is the runners-up. The runners-up is over. Thank you so much. And who is it? Guess. Team 3. You've scored 29, just a little ahead of Team 1. Congratulations. So which college? St. Francis. So read them.
St. Francis, Ms. Sakina, Pujaista, Nimra Samleen, Bhavna and Bhargavi.
Congratulations. Keep this and take their signature. Thank you so much. I really thank Meena ma'am and the team for organizing this quiz, and it was a very enthusiastic session. We look forward for greater participation in the coming years. Remember that on January 10th, every year we will have this program of academic meeting where we will have little bit of enjoyment and little bit of learning. A few housekeeping points. Now we break after the, just to give the mementos to the organizers, and then I'll tell you the housekeeping points.
I request Radha ma'am to present the memento to Dr. Meena ma'am. They'll also be receiving the new published book on clinical nutrition. Critical care nutrition. To Dr. Khushbu Vyas and Ms. Urja ma'am.
We now come to the end of the first session of the academic sessions, and in the afternoon post lunch, now we'll break for lunch. At 2:30, the second session for the workshops, 4 workshops, body composition, enteral nutrition, parental nutrition, and nutrition focused physical examination will start. What you'll have to do is it starts at 2:30 in the 5th floor, not here, it's in the 5th floor. So those of you who've registered for it, please take your token, go up to the 5th floor. There are teams who will actually take you up, and we will assign you to that group. You will be given as A, B, C, D. So the A group goes to one place, B, and then you rotate every half an hour. There are teams who will assist you in that. This is point 1. Point 2 is all those who have not registered for the workshop can take the participation certificate after your lunch. Please fill in a feedback form, and you can avail the participation certificate. The participants of the workshop will receive their participation and the workshop certificate after the program is over. Thank you so much. And for the benefit of all of you all, I really, let me actually have a vote of thanks now. I really thank each and every one of you who've really been here, spending time, taking time out of your busy academic schedules and your practice at the hospitals here for this meeting. It's been really nice to have the full auditorium for this meeting that we've had on the occasion of Dietetics Day. I thank the pharma, especially the Sun Pharma industry, who's actually given us the sponsor to conduct such a large conference. Of course, the extension is the workshop where they've really given us a lot of support in that. I thank my teams in AIG, the branding team, the academic team, the IT team, who've actually given us a lot of support in trying to help us in organizing this team. I thank, of course, not to forget, food is the most important thing. We thank the Food and Beverage Department for giving us real good diet. I thank the speakers, who, especially Dr. Jaleel and the other speakers from Dr. Roop Jyoti, Dr. Rajiv, and then Dr. Smita, who have actually taken time out of their busy schedules, been here to share their knowledge with us to improve our skill set. So this has been a journey for AIG that we always look at trying to improve, give back what we've learned to the community so that as a whole we improve to look at better patient outcomes. Thank you. The participants of the quiz who are there, you can also collect your participation certificate if you're not a part of the workshop in the afternoon.
नहीं मैं तो अकेले लेती हूँ मेरे को गुस्सा आ रहा है हाँ रखो ना मैं लेती हूँ मेरे पास पार्टिसिपेशन we'll go from there.
Technique